All right, I will start my talk today. So it's going to be a little different from what we have done so far, in that in the next hour and a quarter, I'll go through some slides. And while we are going through the slides, we are going to do the practices as well. So instead of giving you a 10 minutes talk, I'm going to talk you through this whole session. And within the session, you will have 6 occasions when you have to do some practices to understand why randomized control trials are the best trials to identify causality between a treatment and an outcome. I don't want to dwell too long on the first part of the session today, which should be about explaining to you the differences between experimental and observational studies. I would like to remind you that yesterday we have heard a lot about the disadvantages and limitations of observational studies. I'll just briefly go through this diagram again and remind you what is the absolute difference between experimental and observational study. So in an experimental study, the treatment is allocated to a certain group of patients in order to understand the effect of that treatment. In an observational study, the intervention happens anyway, and you just observe what follows that intervention. So if the intervention is necessary because of the trial, then we are talking about an experimental trial. And if this intervention is randomized, which you will understand by the end of this session, then we're talking about a randomized trial. If it's not randomized, this intervention, but there are a group of patients who have had the treatment in a non-random way allocated, and a group of patients who did not have, that's a non-randomized but controlled trial. And yesterday we have discussed cohort studies, case control studies, and cross-sectional studies, and we have seen a few examples of those. What are the major differences? So in an RCT, in a randomized control trial, so that's the abbreviation for randomized control trials, RCT, the treatment is assigned to a control group. You must have a control group. In an observational study, you may or may not have a control group. Sometimes, let's say in a cohort study, your patients, there will not be a control group for your disease or exposure, like we saw it in the COVID analysis, cohort analysis for the second analysis, you will remember. Or in a case control study, you will have controls. It is very well described by the type of the study. For each case, you will find, hopefully, somehow an assigned case as well, matched case. So what about the study population in a randomized control trial? It's a highly selected population and in a highly controlled environment. So you can argue that it's not related to real life like the observational studies, but you will have a very specific answer regarding that population who you enroll in that study, who are eligible for inclusion in that randomized control trial. In an observational trial, your population will be very diverse. Directionality. Before you assign your treatment in a randomized control trial, you don't know the outcome. So the exposure is assigned before the outcome is certain. It means that you don't know what is going to happen to the patient when you allocate the treatment, unlike in an observational study, when you are well aware of the outcome of the treatment. If you talk about retrospective studies, sometimes in prospective studies it may not be true. The primary use of RCTs, and probably this is the most important rule you have to memorize, and I would like you to remember when you leave this session. If this is the only, if there's a single take-home message from this session today, it should be primarily the RCTs can reveal the causality. This is the only study type what can ascertain that a treatment is causing an outcome or not, leads to an outcome or not. Observational studies, they can only report on an association between an exposure and intervention and an outcome. So I would say this is the most important message of today's first session. In an RCT, the sample is randomized from the sample groups, and you will understand that while we are doing the practices. In an observational study, you may, or more commonly, you don't use a random sample set for your analysis. The representativity of an RCT, you can generalize to the population, to the highly selected population, the results of an RCT, while in an observational study, generalization is a lot more limited. So, as I said, why is RCT the gold standard these days? This is the only study design in which causality can be proved, as it can measure the effectiveness of a new intervention, and it reduces or minimizes the bias in your studies. It cannot take away all the biases. It can minimize the bias, and you will understand a lot more about biases in randomized control trials when you start to use the bias assessment tools for randomized control trials. They still carry sometimes quite significant biases. And it provides a rigorous tool to examine the cause-effect relationship between an intervention and an outcome. What are the limitations of an RCT? They are limited by ethical and practical concerns. Let's take yesterday's example, Joel's example of does smoking cause cancer? What would be the only study to reveal that causality? We would have to take the population and we would have to randomize them to a group of smokers and to a group of non-smokers, and we would have to follow them up for many decades and look at the end, both treatment groups, the controls and the smokers, and see if cancer is more prevalent in the smokers. But of course, that trial is limited by a very significant ethical issue, which is we have got far too many circumstantial evidence for smoking to be a cancerogenious activity. So we can't do that. That's an example of why they can be limited by ethical or practical concerns. RCTs may fail because we don't perform trials, because they can result in harmful treatments, and they may not be ethical. They may be ethical but infeasible for many reasons, because of difficulties with randomization or recruitment. For instance, patients don't want to participate in the trial because of the smell of an agent which is used in the trial, because of the inconveniences of an equipment which should be used in a trial. Lots of things can generate obstacles, even though the trial, the randomized control trial, could be ethical. Strong patient preferences may also limit recruitment and bias outcomes, such as, let's say, you are carrying out a trial which involves transfusion, And in those trials, you would not be able to include Jehovah's Witnesses. And if there's a population where there are far too many Jehovah's Witnesses, then you are not able to do it because the patient's preferences would preclude carrying out that trial effectively. And the foremost, probably the foremost limitation or disadvantage of a randomized control trial, they need a lot of time, a lot of thinking before you start them, a lot of time while you're carrying them out. And it involves a lot of manpower, even if it's not expensive in terms of consumables. But in the end, it is probably the most expensive type of study and the most time-consuming type of study compared to the other studies we have learned, such as a retrospective cohort analysis, such as a meta-analysis. This takes a lot of time, and this takes a lot of effort and a lot of people to work together. Now that we have discussed that randomized controlled trials are the gold standards for clinical research these days, let's talk about the hallmarks of randomized controlled trials and what is randomization and masking. And I brought you a few practices here today, and I hope that you will enjoy it. Last year it was a very successful practice session. But before we start the practices, let's just briefly go through the hallmarks of an RCT. So in RCT, you will use a standardized treatment. So every patient on the treatment arm will need to have the same predefined treatment, and on the control arm, they cannot have it. You have to have a prospective plan. We have partly discussed, and we will discuss later on throughout the year, that when you design a study, you will need to have a protocol of the study. You will need to register that protocol of the study. And if you are sharp and if you want to do it as best as you can, you even publish that protocol of the study. You have to have an approach and a strategy towards adverse events. So you know how to report your adverse events in your study before you start your study. Of course, an RCT needs to meet lots of regulatory requirements. We have heard that you need to go to the ethical improvement. If some drugs are involved, then even higher legislative governing bodies need to look at your study protocol before you are allowed to do your study. And the two most important hallmarks and features of an RCT, which I'd like to discuss today, is the randomization and the masking. Why do we need to randomize? How do we randomize? Why do we need to do masking, and how can we mask participants in a study? It is important to note that an RCT can have many shapes and forms. They can be parallel studies, they can be crossover studies, there are factorial, cluster studies, and even adaptive randomized controlled trials. But today we are talking about randomization and masking. So according to Wikipedia, randomization Wikipedia says, in the statistical theory of design and of experiments, randomization involves randomly allocating the experimental units across the treatment groups. Now it sounds mumbo jumbo, but you will understand that later on when we do the practices. I think I'm more sympathetic towards the next definition, which is from the Lancet Epidemiology series from 2002. The hallmark of randomized controlled trials is assignment of participants to exposures purely by the play of chance. So it means that it is not the investigator, it is not the participant who decides what treatment is allocated to a certain individual enrolled in the study. It is chance deciding on that. I think that is the core message of it. Aims of randomization, according to Wikipedia, to reduce certain sources of bias when testing the effectiveness of new treatment. And Lancet Epidemiology series says randomized controlled trial is the only known way to avoid selection and confounding biases in clinical research. What I would like, the second message I would like you to take home today, apart from the fact that RCT can only explore causality, is that randomization is a tool in your hands to prevent selection bias. To prevent selection bias, because it's not man selecting the intervention and the control, it's chance selecting the individuals for that. Randomized control trials reduce the likelihood of bias in determination of outcomes. So randomization avoids selection bias. Prognostic factors related to treatment assignment will be equal in both treatment arms. Randomization tends to produce comparable treatment groups. It means when you look at the characteristics of the study population table of an RCT, you should not be finding any significant differences in any characteristics between the two arms, between the participants of the two arms. Randomization can deal with known and also unknown confounders. A lot of confounders are unknown to us when we do a study on a treatment. I have to emphasize that. And randomization can assure the statistical appropriateness of your study. And last but not least, when you randomize your patient, that is the exact time point of the entry into the trial from that individual's point of view. So that is the point from where you start to measure the length of hospital stay, for instance. That is the point from where you start to measure the mortality, etc., etc. So it's a very defined time point as well. You will remember this example. This is an observational trial in which aspirin increased the cardiovascular deaths because the patients were not randomized. It was a retrospective analysis, and selection bias was so high that patients who were enrolled on the aspirin in the aspirin group died more commonly and more often, of course, because they were nearly 10 years older than the no aspirin group. This is the kind of selection bias which is inherent in observational studies, even if they are prospective. Now, let's do the practices. And before we do the practices, I would like to tell you that we are going to look at two types of randomization. The first two practices will be about simple randomization. The third and the fourth practice will be about restrictive randomization, and you will understand what they mean as we go along. So simple randomization is the toss of the coin. Does everyone understand what the toss of the coin means? So it's feldobom a pénzt, elkapom a pénzt, fej vagy írás. People who don't speak Hungarian, can you confirm to me that you understand what is the toss of coin and what the head and tails are? Good, okay, fantastic. So we have got this practice for each and every room, and I would like to appoint someone with a coin. So, and I ask all teams to do that. So we've got a person to toss a coin. We've got a person with a paper and a pen, And the first exercise is that we have got 10 patients. The first patient who comes through the door of the hospital and who you want to enroll is a male and he is obese. The second is a female and he is non-obese. The third is a female and again non-obese. So these are the patients who are consecutively can be enrolled in a hypothetical study, and your equipment to randomize them is a simple randomization method, which is the toss of the coin. So I'll ask each room to do, we're going to do the first patient together. So do we have a coin? Eduard, you're the coin man in our room. Eduard doesn't have money. Who has money? I've got money. I'm full of money. Can you do the toss of the coin? I don't know. Okay, I'll do it then. So we're going to do the first patient. I'm not telling you what is it at our end, but we have got a randomization for our first patient, and I'd like you to do for the rest of your lot. Can you do it? Whoever does it. I would like to ask all teams to answer the first two questions. Nori's team, how many patients have been allocated to A and B?
6 patients in the treatment A and 4 patients in the treatment B group.
What is the allocation ratio?
6-4.
Yeah, 6-4. All right, let's go to Fanny's team. What is your allocation ratio?
3-7.
Sorry?
3-7.
3-7. So treatment A 3, treatment B 7. What happened in Peter's office?
We have 4-6.
4-6. And in our room, we had 3-7. So what we couldn't achieve a 1-to-1 treatment allocation ratio or allocation ratio. Now, more interesting is the distribution of major confounders. If we assume that this is a treatment we want to assess in this randomized controlled trial, where the major confounders are the gender and BMI, what happens? I'm asking Peter's office again. What is the distribution of major confounders? First for the gender and second the obesity on both arms.
So in the first arm we have 3 males and 1 female, and we have 1 obese patient and 3 non-obese. And in the second arm, we have 2 male and 4 female patients, and we have 4 obese and 2 non-obese patients.
So, in a nutshell, so this way, simple randomization could not help you to have equally distributed confounders in each treatment group. Can we go to Nori's room? Did you have the same experience?
In the first arm, we have 3 males and 3 female patients and 4 obese and 2 non-obese patients. And in the second arm, we have 2 male and 2 female patients and 1 obese, 3 normal or non-obese patients.
All right, so we can say that although gender was equally distributed on both arms, but obesity was. I won't dwell on that too much because we had the same kind of experience. Interestingly, we had one arm where there weren't non-obese patients. So treatment B was, for example, in our case, only patients who were non-obese. The simple randomization wouldn't allow you to achieve an equal one-to-one treatment, one-to-one allocation or any desired allocation ratio, and it will not help you to evenly spread the confounding factors between the arms. Let me just explain my next slide. I'm not sure why it's not working. All right, so we have got the same randomization method. We're doing a simple randomization again, but we have a larger sample we have to randomize. You've got 32 patients, and you have to do exactly the same what you did before. Can we do it? Can you do it? And we can reconvene in 5-6 minutes. Nori, what happened to your lot? How many patients have been allocated to A and B?
In the treatment A group, we have 18 patients, and the treatment B group we have 14. And in the first arm we have 12 males and 6 females, 7 obese and 11 non-obese patients. And in the second arm we have 4 males and 10 females and 5 obese and 9 non-obese patients.
Okay, what happened to Fanny or lot? Fanny and team?
Yeah, I'm here. In Group A, we have 17 patients. In Group B, we have 15 patients. And in Group A, we have 7 males and 10 females, and 6 obese and 11 non-obese patients. And in Group B, we have 9 males and 6 females, and 6 obese and 9 non-obese patients.
I'm asking my team to share their experience and results.
Yes, in Group A, we had 10 patients, 5 male, 5 female, and 8 of them are obese and 2 of them are not obese. In treatment B, there are 22 patients, 11 female, 11 male, 12 of them are not obese, and 10 of them are obese.
All right, Lonnie and team.
So now we have in Group A 17 patients, of whom 10 are male and 7 are female, and also 8 are obese and 9 are non-obese. And in the Group B, we have 15 patients, 6 male, 9 female, and 4 obese and 11 non-obese.
Perfect. Szilárd?
Lila?
Yes, we had 16 patients in both groups. In Group A, we had 8 males and 8 females, and
Wow!
yeah,
What happened?
and 6 of them were obese and 10 of them were non-obese. In Group B, we had 10 males and 6 females, and 10 non-obese and 6 obese.
Fantastic.
Quite a good allocation, I think.
Yeah, and I think we can make the point, and I'll move on with my slides. Thank you very much for your contribution to this practice. Advantages. The simple randomization and the toss of the coin is a way to simply randomize a sample. It's a type of complete randomization. Each assignment is independent. So when I toss the coin on the second occasion, it is completely independent, the result of that randomization from the previous one. Each assignment is completely unpredictable, and what you could say, in the long run, number of patients that's assigned to each group should be about equal. So we have seen that if we do this simple randomization only for 10 patients, that is quite unequal. If we increase the number to 32, the numbers seem to be more kind of equal than if you do it on a smaller sample size. Simple randomization causes imbalances in the number of patients assigned to treatment and control groups. We had 2 or 3 teams where the treatment allocation ratio was 7:3, I think 2, and then 2:6:4 if we had low sample number. And for a larger sample number, these imbalances even out. Confounding factors are very, very imbalanced if you do simple randomization. And because of this, the results of a study with simple randomization may diminish the credibility of a result. Let's say we would have done the study with 10 patients in which one of the study arms only had obese patients, where we know that obesity is a major confounding from the intervention's point of view. That diminishes the credibility of that particular study's results. And the risks, these kind of risks of simple randomization are inversely associated with the number of participants. So if you work in a large hospital where you do want to do a single center study including 300 patients, then simple randomization may be the way to deal with this problem. But most commonly, you will do randomized controlled trials in multiple centers, and some of the centers will have very few patients enrolled in the studies. And for instance, one of the major confounding factors in a randomized controlled trial is actually the site of the treatment, not the patient's different characteristics. And in that case, you have to make sure that in that center, treatment allocation remains the desired, and the patients are randomized like that. And we are moving on to restrictive randomization. So we want to overcome the problem of undesirable allocation ratio, and we want to overcome the problem of unequal distribution of confounding factors across treatment arms. And exactly for that 2 purposes, we can use 1, blocking, 2, stratification. So these are the types of restrictive randomization. Usually in a multicentric study, you would use both approaches. So your randomization will be blocked and will be stratified. The block, it's very difficult to understand, but I hope I'll be able to explain to you. So we all understood that the treatment allocation is decided by randomization before the actual treatment is allocated to the patient. And if you don't use simple randomization, and if you want to ensure that a certain allocation ratio is achieved throughout a study, then you can use randomly assigned blocks of treatment assignments. So if you want to achieve a 1-to-1 allocation ratio for treatment A and treatment B, you can use a block size or block of size of 4, 2 A's and 2 B's, and you can list all possible permutations like AA, BB, AB, AB, and so on and so on. And these randomly permutated blocks are generated by some sort of clever equipment, most commonly computers. Size of the smallest possible block is the sum of the integers defined in the treatment allocation ratio. For instance, if you have got a 1-to-1 allocation ratio, then the smallest block size you can use is a 2. if the treatment allocation ratio is 2:1, then the smallest block you can use would be a block of 3. Larger block sizes are multiples of smallest one. All possible block sequences are randomly permuted. That means that they are arranged in all possible ways. And it randomly chooses one of the many permuted blocks. Block randomization ensures the treatment allocation ratio over time. So if you use blocking in your randomization, at any time point, you can stop the study, or at any time you have to stop the study, you will have equal number of patients on both arms. And that's a huge advantage. Even if you have only 10 patients or 12 patients enrolled in the study, you can be sure that the treatment allocation ratio of 1:1 is ensured if you use blocking. You cannot change the allocation ratio later in the study. You have to decide on a treatment allocation ratio before you start your study. The blocking is a secret. You don't know what is happening in the background. So you don't know the actual blocks. It's only the computer, the random sequence generator, we call it. The random sequence generator is the only place where you could discover what is the blocking. Of course, you can know it if you have to break the code. And do use more than one block size. So don't just use blocks of 2. If you've got 1:1 treatment allocation ratio and you've got many hundred patients to randomize, do use 2 blocks of 2, blocks of 4, and blocks of 6. And you can even randomly change these permuted blocks. Now we're going to do block randomization. It's not going to be, you don't need a toss, you don't need to toss your coin now. Instead, we are tossing an imaginary coin, or we rather use an imaginary random sequence generator. And our random sequence generator says that the first block what we have is an AB, which means the first patient is A and the second patient is B. So patient 1, who is a male and obese, is treatment A. The second is female and non-obese. And our random sequence generator spits out an ABBA, like Mamma Mia. No, I'm joking. So the third patient is A, the fourth patient is B, the fifth patient is B, and the sixth A. And I'm projecting all the following blocks. And the questions will be the same in the end, of course. Treatment allocation ratio and confounding factors in your treatment arm A and in your treatment arm B. I'll let you work. Nori? Norbika, mondod?
Yes. So the allocation ratio was 16:16, and the confounding factors in the first arm are 10 males and 6 females. In the second arm is 6 males and 10 females.
Yeah.
And in the first arm is 9 obese and 7 normal.
Yeah.
And in the second arm is 3 obese patients and 13 normal patients.
So very uneven number of confounding factors across the 2 treatment arms. Any other experience from the different sites? Did you have the same experience, Fanny? I hope you had 16 on both arms. But was it able to ensure this type of randomization to have the confounding factors evenly distributed across the 2 arms? the question? We can't hear you. Fanny and team. I'm asking Fanny's team. I'm not asking Fanny, sorry.
Okay, so
We don't believe so because there are only three. I don't know if you heard me screaming. So we don't believe so because there are only 3 obese people in Group B, as there are 13 non-obese.
I don't want to check what the other sites and other offices found, because what I wanted to prove by doing this exercise is that restrictive randomization and blocking can tackle the problem of the allocation ratio, and any room can confirm that we achieved the one-to-one ratio by using this blocking approach, but we were unable to deal with the problem of the confounding factors. The simple randomization is good for large samples if you do the randomization in a single center. Blocking is very good if you don't have a large number of participants in a study, but can ensure that the allocation ratio is maintained throughout the study. And had we stopped at the 16th patient doing the randomization, we would still have had one-to-one allocation ratio. You can easily understand that. But it's not good to deal with the confounding factors. And there are known confounding factors in each clinical study. So let me move on with my talk. So the advantage of blocking overall balance, especially in smaller trials, protects against time-related changes, which means at any point in time you have the one-to-one allocation ratio. It helps it protects against time-related changes in the data collection procedures. And if the trial is stopped early, you have balanced groups. And the analysis, therefore, are more powerful than with simple randomization, because we have seen that if you use simple randomization, the allocation ratio may not be desirable. Disadvantages, it can facilitate the prediction of future assignments. So if someone understands, if your randomization is blocking randomization is poorly executed, then the participants or investigators can predict the future assignments. And blocking is more problematic for unmasked trials or poorly masked trials, and we'll learn about that later on. The other type of restricted randomization is the stratification. It can ensure balance in treatment assignments within subgroups defined before randomization. The most common types of stratified randomization is you stratify for the actual site, for the actual clinic, for the actual hospital. You stratify for a gender, you stratify for a risk level, you stratify for a stage of cancer, you stratify for BMI, as we saw. And these subgroups should be related to the outcome, strong confounder or effect modifier. It requires a separate set of treatment assignment schedules for each category of each stratum. And I brought you an example, and hopefully you will understand. There's a breast cancer, and you want to have a one-to-one treatment allocation for treatment A and treatment B. And you want to ensure that you have equal number of treatment A patients and treatment B patients in both centers. And you want to make sure, because one center is a center of excellence and the other one is not. And you want to ensure that the postmenopausal status is equally spread. between all treatment arms and also the centers. So what you use, for instance, in this trial, block sizes of 4. For instances, for patients who are enrolled in center X and are pre-menopausal, they get a block of 4 of BBA. While in center Y, premenopausal patients get a different block. In treatment center X, for postmenopausal patients, they get a block size of 4 with BABA, and lastly, in treatment center Y for postmenopausal and AABB. So basically, these randomly permuted blocks are dedicated to patients, enrolled patients, depending on the center and depending on their pre or postmenopausal state. So when you enroll a patient, first you have to know which center you are in, and if the patient is pre or postmenopausal. But let's do the practice on our well-known sample of 32 patients. And let's assume that in the study where we have obese patients and non-obese patients and males and females, the major confounding factor out of the 2 factors is the gender. And we want to make sure that we have got equal number of females on treatment B and equal number of males on treatment A. And therefore, your random sequence generator spits out the following blocks. For the first female patient, which is number 2, you will get a B. For the second female patient, you will get an A. For the third, you will get an A, and so on. And the same for the males as well. Could you do it, please? And then we'll have the same questions in the end, apart from obesity. I will not be interested in obesity because we know that the confounding factor here is the gender. So this is an example of blocking and stratification, so very complex approach to randomization. So I'm very impatient to learn the news. How many patients have been allocated to A and B? What is the allocation ratio? And has this approach helped us to allocate equal number of females and males to A and B? Esther? Esther said yes, yes, yes. Any other views from any other offices? Wally, could you do it this time?
Yes, this time we could do it. Thank you.
So of course we have 16 patients in each group,
Yeah.
and gender distribution is equal in both of them. And we have in group A 6 obese patients and 10 non-obese, and in group B we have 6 obese patients and 10 non-obese.
Fantastic. I think we had similar results in all groups. But basically what we wanted to demonstrate here with this practice is that if you use blocking and stratification for your most important confounding factor, you can ensure that your samples will be comparable. What is happening here? A few practical aspects of stratification. You can stratify for at most 2 variables. These variables are highly related to the outcome. So for instance, if it's obesity, which or the gender, which is the most important factor from the outcome point of view, then it should be gender. Logistical variable can be another example. a few typical ones we have already discussed, that if you do a multicentric trial, number one stratification is usually the stratification for sites. Alternatively, for instance, in a surgical randomized control trial, you can stratify for surgeons. You want to make sure that equal number of different types of surgeries goes to each surgeon. You can stratify for stage of a disease, stage of cancer, stage of kidney disease, etc., etc., and also demographic characteristics, as we did in our instance. However, too many strata may lead to imbalances in overall treatment group allocation. So as I said, you usually limit your stratification to one or two variables, like in the example I gave you, where there was stratification for the site and stratification for the menopausal state, pre and post-menopausal state, because we wanted to make sure that in both centers there are equal number of pre and post-menopausal patients allocated to both arms 1-to-1 ratio. Now, we are moving on to masking. But before I start to speak about masking or blinding, I would like to summarize what you had to take away from this little practical session on randomization. So randomization is generally the process where the role of choosing a treatment, an intervention, or a control for a participant is handed over to chance. It's not done by man, it's done by chance. Now you can always regulate chance, and you can be restrictive with chance, and sometimes you need to do that, and you need to use restrictive randomization. And the two most important forms of restrictive randomization is blocking, our blocking, and stratification. Now, did you want to ask something? All right. So masking, according to Wikipedia, in a blind or blinded experiment, information which may influence the participants of the experiment is withheld until after the experiment is complete. In other words, if you're a doctor, if you're a patient in a study, you don't know what you do, you don't know what you get until the experiment is complete, which is when the whole study is complete. So not just your treatment, but the whole study comes to a conclusion. According to Coursera's educational material, treatment assignment is not known after randomization. So basically, blinding is a way to ensure that the treatment allocation remains a secret throughout the study. Aims of masking: good blinding can reduce or eliminate experimental biases that arise from the placebo effect, the observer effect, confirmation bias, and other sources. According to Lancet, blinding usually reduces differential assessment of outcomes, information bias, but can also improve compliance and retention of trial participants while reducing biased supplemental care or treatment, sometimes called co-intervention. We have agreed that the best way to ascertain causality in a clinical trial, or the best method, is doing a randomized control trial, in which between the two arms of the patients, or two groups of the patients, only the treatment is different. And the difference in the outcomes, therefore, is caused by the treatment. Because if you don't do a randomization, or if you don't do the randomization well, you do so-called quasi-randomization. Let's say every patient coming in on a Monday, Wednesday, and Friday, they will go to treatment A, Tuesday, Thursday, and a weekend, that will be treatment B. That's pseudo-randomization. There will be a systematic error which then cause bias in your study. You have to do your randomization. And that prevent selection bias, your randomization. If you maintain the advantage of randomization throughout the study, if you want to, then you have to blind your participants and investigators. And with that, you can reduce performance bias and detection bias. If you don't know what your patient is getting, you will not make a difference in their care. If you know, for instance, that one of the patients gets a new experimental antibiotic, which seems to be much better than the older one, you will request a far more chest X-rays in the control group because you don't trust the old drug. And if you suspect pneumonia in those patients, you'll have a lower threshold of requesting a chest X-ray. That's an example of performance bias. Masking ensures and blinding ensures that the advantage you achieve by excluding selection bias by good randomization is maintained throughout the study, and you don't let to creep in, you don't let performance and detection bias creep into your study. Choose the outcomes for which masking blinding is a must, not just should. This is practice number 5. So we've got outcomes, length of hospital stay, mortality, pain on a visual analog scale, hip fracture, myocardial infarction, quality of life by questionnaire, recurrence of cancer. I am asking which team hasn't answered in the previous round. Szilárd, can you discuss with your team which is the outcome for which are the outcomes for which masking is a must?
Yes, you can.
Please discuss within your groups. You've got 2 minutes, everyone. So what's the answer, Szilárd? Could someone from your team tell us which is the outcome for which masking is?
We are coming back in 20 seconds. 10 seconds.
9, 8, 7.
Balint.
Yeah, that's my name. Don't wear it out.
Okay. So we did not have the time to finish all of them.
Do you have to blind for length of hospital stay in a study? If your outcome is length of hospital stay.
Blind for who? That was our question. I mean,
all participants, investigators and participants, I mean. All right, I'll ask Lolly's team if they are happy to answer the question while you are thinking about.
We talked about it. I think on the one hand, it's absolutely beneficial because there could be factors prolonging the hospital stay, for example, just by I do another exam, which prolongs. Just because I know which treatment group the patient is allocated, that's why I do another exam. That might be a possible factor. But on the other hand, in the case if there are previously fixed is discharge criteria, then it's not necessarily a must for blinding, because if a patient has, for example, no fever or has negative tests and it's a fixed outcome, then the fixed discharge criteria, then it does not changes. That was our thinking.
Any other views? So we have come to a conclusion in our little group that basically, apart from mortality, they are all so-called soft outcomes, not hard outcomes, and mortality cannot be influenced by the study being an open label study, that is the lack of blinding. But for any other outcomes, we think that masking or blinding is essential to measure accurately, because length of hospital stay can be heavily influenced. For example, if you know the patient takes an experimental treatment or on the control treatment, depending on your preference. Anyway, this is a good topic to discuss in the coffee break. And before we have a coffee break, we have got a few more slides to go through and a little more exercise. I already explained to you that most common blinding in our cities is double blinding, when a patient doesn't know what he takes or what she takes, and neither the doctor does. You can have triple blind and quadruple blind trials when the assessor of the outcomes are blinded, when the statisticians are blinded, and everyone is blinded, and the data is coded. Potential benefit accruing depend on those individuals successfully blinded. Participants are less likely to have biased psychological or physical responses to intervention if they don't know what they are getting. Participants are more likely to comply with the trial regimen if they don't know what they are taking, whether it's a placebo or the actual experimental drug. They are less likely to seek additional adjunct intervention. They are less likely to leave the trial without providing outcome data. Because if it's unblinded and if you know that you're on a placebo, you will be more prone to leave the trial prematurely, leading to loss to follow-up. From the trial investigator's point of view, it's less likely to transfer their inclination, their attitudes to participants. It's less likely to differentially administer co-intervention, to differentially adjust the dose of the drug, differentially withdraw patients, and to differentially encourage or discourage patients to continue the trial. From the assessor's point of view, it's less likely to have biases that affect their outcome assessment, especially with subjective outcomes of interest. And the previous practice should have emphasized the importance of the fact that barely anything else than mortality, or nearly anything else other than mortality, is a soft outcome, a subjective outcome. Even hip fracture can be a subjective outcome. So the take-home message: use the most appropriate randomization scheme, use a proper random generation system. So forget your coin. It's very good to practice and understand randomization. You use a computer which then randomly generates a sequence for you. And when that randomization happens, mask and blind when the outcome measures are subjective. So basically in any study. Now it's practice time again. Practice 6. Compare the two studies which you have on your desks. We have got 2 studies for each team, and we have got very simple questions. I would say that Fonni's team should answer question 1. Lali's team should answer question 2, Nuri's team question 3, Silad's team question 4, and my team will answer question number 5. You have got 10 minutes to work. We are already in my little team, so I would ask to do the questions as I suggested we do. I think question number 1 was conference room Maciek.
Yes, for question number 1, we have the following answer. So in one of the cases, the randomization was performed with the use of a computer-generated sequence with a block size of 9. And in the other case, the randomization was generated by an independent biostatistician who performed the whole thing using the RELOC module in STATA v14. And comparing these two, we think that in the PLACID study, the randomization sequence was more correct because they have used an independent biostatisticians, while in the other one, there could have been anyone else involved in the study who did the randomization, which is not very correct.
Any other thoughts from other rooms? Four more questions before the coffee. Were the random allocation concealed from patients and investigators in the 2 studies? What is the answer to that question? Sounded like a little part.
It's not the first time.
Can you hear me?
I can hear you.
Okay, so the first, the budesonide formoterol study was randomized, but not matched. It was matched only until blinded until the randomization, and the other one says that it was blinded, but it doesn't say how.
Sadly, we can barely hear you, but what I would like to say here is that it's enough to read the titles of the articles, because one of them says that open label phase 2 multi-center randomized control trial, the PLACID trial for the COVID-19 patients in India. And when you read open label, that means anyone can read the label of the drug he or she is taking. So that's not a study where the random allocation is concealed, and neither is a study where the participants or investigations are blinded. So when you read the words open label, that's the opposite of blinding, okay? That's the message I want you to take home. Question number 3, were the randomization schemes restrictive in any of the studies you read there? And I remind you that restrictive randomization is blocking or stratification or both. So were the randomization schemes restrictive in the studies you have looked at? Who is doing question number 3?
Both of the studies used stratified blocking randomization.
Perfect. That's the answer we found ourselves. Any other conflicting answers from other rooms? All right, then question number 4. Were intervention and control groups comparable at baseline?
Lila, can I ask you to answer, please?
Yes, in both articles, we could find a table where they wrote about both of the groups, but both tables were lacking the statistical comparison between the two groups. But if we look at the values, we could find that both in both articles, the two groups were more or less comparable.
Yes, probably if you looked at, if we had time to look at the supplementary material, we would be able to find out, or maybe it's somewhere hidden in the text, that there were no significant.
We tried to find that, but unfortunately, neither in the results, we couldn't find it in the results, this part. So
Yeah.
probably both articles like this.
And what I wanted to emphasize here is that these tables usually contain the known confounders, regarding a treatment and its outcome. It doesn't contain the unknown because we don't know them. But the beauty of randomization, that the unknown confounding factors are also likely to be evenly spread between the two treatment arms. And that is kind of that gives us the certainty that only the treatment is different between the two groups, and therefore this is the only way to assess causality in a clinical trial. So the last question to my team: were participants and study personnel blinded? Edo or someone else who wants to answer this? Come closer. You have to talk in there.
The asthma trial participants, investigators, and the statisticians were not blinded. They were all aware of the treatment group assignments. While in the COVID trial, it says that after stratification and randomization, a member of the central trial coordinating team was contacted, and he or she gave the randomization sequence, ensuring concealment of allocation.
Any other views? Any other information which you want to share from other teams? I take it as a no. And with that, I'd like to conclude this rather long session. I realize that we seriously over time, and therefore I would suggest we have a slightly longer coffee break than the program allows us. I'm asking the course coordinators, when should we meet up again instead of 3? Wally, Nori?
In 30 minutes, so 30 minutes coffee break.
30 minutes?
30 minutes, yes.
Oh, I love you. You're so generous. Thank you. Wonderful.
Okay. Thank you for your feedback. I think then we shall proceed because we have a lot to discuss. So what I would like to talk about now are the interventions and outcomes of a randomized controlled clinical trial. So this is what we should discuss now: the interventions, the outcomes, the potential metrics of outcomes, and some quick examples regarding the interventions and the outcomes. The intervention, when you choose the intervention, you have to design the randomized controlled trial that the intervention should affect the clinical phenomenon, should affect the outcome. Now, of course, intervention should be standardized and should be clearly defined. You have to say what you mean by that intervention. For example, just by my examples, when you are talking about esophageal esophagectomy in the case of esophageal cancer, that can mean a lot of things. That can mean 5 different types of methodologies. But you have to clearly define what you mean by that intervention. Of course, that intervention needs to be reproducible. It can be invasive, non-invasive, preventive, therapeutic, or an acute or chronic intervention. When we are talking about outcomes, the outcomes are usually quantitative measures, and they should reflect the objectives of the trial. So they should answer the questions of efficacy or effectiveness. We will talk about the difference between efficacy and effectiveness. They have to address the problem, or they should address the problem, safety of process or costs regarding that clinical trial. And they are usually determined in each and every study participant. Now, there is a hierarchy of outcomes. The most important outcome, which you think the most important is regarding that clinical question, should be your primary outcome. One should always choose a primary outcome which reflects the objectives and the primary hypothesis of that clinical trial, and which is the most important and the hardest one. When you are designing your clinical trial, the sample size calculation will be based on that primary outcome. Of course, if you would like to have a bigger picture and you would like to obtain additional information regarding that clinical question, you can include secondary outcomes, which can address other important potential effects. It also allows a more complete evaluation, like a risk-benefit evaluation regarding the clinical question. Also, you can address other outcomes, for example, which are addressing the problem of patients' health or participation or the compliance, the question of compliance. The primary outcome has to be relevant and has to be likely to be influenced by the treatment. It should be it should be measured accurately and reliably, and we should be able to evaluate it in all patients. And the assessment should be independent of treatment assignment, which means that that assessment of that outcome will not be associated with bias. Talking about the metrics of an outcome, the outcomes can be a dichotomous variable, which means that there are only 2 options. Either the condition is present or absent. It's basically a yes or no question. It's rather a clinical state, or if you are talking about a continuous variable, you can estimate a cutoff value above which you say that above this value, this will be a presence of the condition. So basically, you can make a continuous variable into a dichotomous variable. Typically, the dichotomous variables are assessed at the specified time point. Regarding another type of metric of an outcome, the time to event can be also addressed. It adds a dimension of the time to the dichotomous variable, and it's usually more powerful than the dichotomous variable itself. We can also assess rates, but to assess rates, we need follow-up. We need to follow up this patient. And only those variables can be measured by rates, which allows repetitions. We can also have composite measurements. And when we say that 2 or more events are related to a disease process. So, for example, we are saying that regarding a clinical question, mortality or ICU stay should be the composite measures. It could be considered dichotomous or time to event, or even we can even calculate rates. Of course, we have continuous variables when we are assessing a value of an outcome. Or we can also say that we are curious about how that continuous variable changes from the baseline. These are usually standard units like laboratory values, for example. Of course, in these cases, repeated measures are also possible. We can also have ordinal variables, which are ranked categories, like the stage in the case of cancer or oncological, in the case of oncology. For example, adverse event severity can be also an ordinal scale. But the difference between the categories is usually a qualitative, not a quantitative difference. Outcomes can be objective or subjective. Objective outcomes are usually the hardest outcomes, and there is a rigorous definition which will limit the interpretation. So this is an objective outcome. It may include test results for confirmation. Now, on the other hand, subjective outcomes rely on judgment and rely on subjective judgment. For example, patient-reported outcomes like pain scale, visual analog scale, or observer-reported outcomes like quality of life. When we are talking about effectiveness or efficacy, the difference between these, that the efficacy is a more objective variable. It's an outcome which assesses the question in a more of a objective environment, while the effectiveness assesses the same problem in the everyday world. So for example, in the case of a new drug regarding asthma treatment, when we are trying to assess the primary outcome, in the case of hospitalization or steroid courses, it describes the effectiveness. But in the case of efficacy, the FEV1 can be described because it assesses the same outcome, the same question, in a more objective manner. For example, we have a HIV clinical question, and we are trying to assess the following outcomes, which are the survival, immunological response, virologic response, change in patient status, specified toxicity, and other side effects. Now, the side effects and the toxicity are referring to the safety of that newly administered drug. The immunologic response and the virologic response referring to the short-term efficacy. The survival and the other side effects are referring to the long-term efficacy. And the survival, the change in patient status, the specified toxicity, and other side effects will refer to the long-term effectiveness. Now, how do you protect your outcome? Bind already talked about this, that you can apply randomization or masking, or even intention treat analysis about what one of our biostatisticians will talk about will be David Nemeth. Now, my take-home messages from this presentation is that you should always choose the best primary outcome, which is usually the hardest one. Define your intervention as detailed as possible, and the primary outcome, as outlined in the protocol, always must be assessed. Now let's move on to the practice. These are the following questions which we should answer. Please take the article to your hand, which assesses the problem of the asthmatic drugs and asthmatic treatment. You will have around 15 or 20 minutes to assess these questions. And after this, you can already see which questions will, which groups should answer which questions. Thank you for your attention.
Lolly,
yes.
Are we looking at both articles?
No, only the asthma drug.
Okay.
Okay, I think you are ready too. Szilárd, are you ready with the online room?
We are ready because our room ended, so we are back.
Oh, very good. Let's begin with
We can't hear you very good.
You cannot hear me, even now?
I mean, it is like you are in a cave or something.
Huh? Okay.
Is it better now?
Much better.
Much better, very good. Now let's start with question 1, and I'm asking the library, what was the clinical question? What is the hypothesis of this particular study?
Okay, the answer can be found at the end of the introduction, that we carried that the hypothesis was that whether as needed budesonide and formoterol would be better than a SABA or
Yes, okay, that was the clinical question, right?
Okay.
And what was the hypothesis?
The hypothesis was that the as needed budesonide formoterol would be better than as needed SABA and as inhaled glucocorticoid maintenance therapy plus as needed SABA.
Okay, thank you. I think we already discussed the question 1. Or does anyone, any other group have an insight? Another insight? If not, then we can. I'm asking the Macsek tárgyaló, what were the interventions and whether they were clearly described? Macsek tárgyaló, can you hear me? Can you hear me, Macsek tárgyaló?
Yes, yes, yes. Hi there. So,
Fanny.
Hello? Hello? Can you not
We
hear
can
me?
hear you, but can't you hear us?
We can hear you well.
Okay. Yeah, so the interventions as described.
Stay no, my right hand. Fanny, can. Okay, then I will just move into the other. Okay. Now, can you hear me?
We can hear you. Can you hear us though?
Very good. Okay, I didn't hear.
We can hear you both.
Very okay.
I can't hear Nori.
Okay, so Macsek tárgyaló, please. Can you answer question 2?
Yes, as written on the very first page, actually, in the abstract, there were 3 groups. One of them treated with albuterol only, 100 micrograms to be exact, 2 times. The other one with budesonide, 200 micrograms, one inhalation twice daily, plus albuterol as needed. And the third group being budesonide, formoterol, and that's it, basically.
Yeah, okay. Are you satisfied with the description of the interventions?
We are, because they even went a step further. If you look at the randomization and treatment part, they have even told us exactly which brand they're using all the time, which means they actually made sure that it's the same product every single time.
Okay.
That was our answer to the question.
Okay. You heard me? Did you hear me? Nori, can you give us your insight regarding the question 3 about the primary outcome and whether the definition was sufficient enough.
Yes, it's also stated pretty clearly. It even has a separate section. The primary outcome was the annualized rate of asthma exacerbations per patient. And after this, they are going into detail what this means. So they are pretty clearly described.
Okay, thank you. We can move on to question 4. Which outcomes were assessed and whether they were soft or hard outcomes, or we should only focus on which were the softest of these outcomes? And I'm asking my group to give our opinion on this question.
The primary outcome was the annualized rate of asthma exacerbations per patient. This is a hard outcome. There were a lot of secondary outcomes. And the soft outcome was the asthma control question.
Okay, so we discussed that the softest these outcomes were the score which they tried to assess. Okay, does anyone have anything or any question or any insight regarding these questions? Okay, I take it as a no. So let me hand over the mic to David.
Can I very briefly reflect on your last question? Is there anything to add?
Yes.
So if you look at a journal, if you look at an article, you obviously realize what journal it is from. And we can all see that this is from the New England Journal of Medicine. And if a trial is accepted to New England Journal of Medicine, you would suspect that there are certain standards achieved by the authors in their study. And I think we have seen a very good example of a clear clinical question and hypothesis, very well defined and described interventions and outcomes. And this is often not the case if you look at articles in lower quality journals. So I think that's my reflection on the questions and the answers. And one other thing which I'd like to say is that in a good article, the information is there and it's easy to find the information. And that's what we see. That's what we saw in this instance, I believe. Thank you very much. That was my comment.
Thank you, Balint, for giving your insight. If everyone is satisfied with this discussion, then I will just hand over the mic to David Németh, who will give us a lecture about the statistical considerations regarding clinical trials. So, David, the stage is yours.
Thank you. So, good afternoon, everyone. It's not a break. My name is David Németh, and I would like to talk about special considerations within the statistics session. So here you can see the main topics I would like to talk about, such as sample size, data, subgroup, and per protocol analysis. First of all, let's see the connection between sample size and confidence interval. It is important to know that the smaller the confidence interval is, then it is more accurate, like I mentioned yesterday. And the length of this interval will decrease if we increase the sample size, which is good for us. But working with a too high amount of sample is wasting. So the sample size has to be as big as we can just reach the required accuracy. For that, the statistician group can calculate a sample size estimation. For this estimation, we will need a clear and precise null hypothesis. So at this time, we need to know the null hypothesis. And then we have to calculate the estimated required sample size before the research. We want to verify or reject the null hypothesis, and for that, we perform a sample size estimation to know how many subjects do we need to evince the difference. So calculating the sample size is essential to reduce the cost of a study and prove the hypothesis effectively. It is important to know how many patients do we need, so we could compare the benefit with it, and we will be able to decide if it's worth or not. For the best sample size estimation, we need the result of the previous researches, because the estimation is more accurate if we know what was the outcome for other researches. That is the easiest way to make the perfect sample size estimation. If we cannot find any previous publications about the topic, because of course that can happen, then we just groping in the dark. So it is more difficult to estimate. That is why our estimation will be uncertain. In this case, we prepare pilot studies, which are small-scale preliminary studies, which aim to investigate whether crucial components of a main study will be feasible. For a sample size estimation, we need the mean and the standard deviation if it is a continuous variable. In case of the atom, we need the percentage distribution. That means we need, for example, the number of the patients who have taken medicine and died, which can be the event, and who take it and survived, which can be the non-event. And of course, we need to know the number of patients who died without the medicine, which is the control, and who survived, which is non-event control. The event and control groups can be changed based on the hypothesis. Here you can see the main rules about the data we need. First of all, when you prepare the Excel sheet, it is essential that you should use one type of data in one cell. And for every column, you should use labels, so it will be easier to understand. We need only raw data and not percentages. And one measure of variability for one measure of central tendency. So mean with standard error or standard deviation, or median with range or interquartiles. There are some special cases when we need a p-value as well. For example, when our data looks like this. This is the changes of fertility parameters using vitamin D. In this case, we have a before and an after value as well. So we need both means and both standard deviations, and we also need the number of patients and the p-value, like in the green rows. When we want to compare two diagnostic methods, for instance, we need data such as true positive, false negative, and true negative numbers of patients. I just wanted to show that this kind of analysis also exists, but I don't want to talk a lot about this because it's not really common. And if someone needs an analysis for this kind of data, the statistician can tell us what kind of raw data do we need. Most importantly, subgroups. Sometimes we realize that our data or our results seems to be really different. That means we have a high heterogeneity. The quality of our data or results are heterogeneous when they are dissimilar. There can be plenty of causes behind the heterogeneity, such as different scale. That means the values are measured on different scales or with different methods. The reason can be also the different patient characteristics. For example, when the values are different between men and women. Or it can be a different treatment as well. When we have a high heterogeneity, sometimes it is appropriate to prepare a subgroup analysis. A statistician can see that it is a high heterogeneity in the results, but the researcher have to cut the data into 2 or more groups based on a medical reason, for instance, but just if there is any reason to cut it, of course. Here you can see an example for the subgroup analysis. In the red square, you can see the percentage of heterogeneity, which is 98.5% in this case. And if you look at the forest plot, you can see that the data seems to be different in the green and the yellow square. So in this case, we should analyze them separately. But just if there is a real reason to do that. For example, if the studies in the green square are from China and the yellow ones from Europe, that can be a reasons to separate them. And of course, there will be a lot of other reasons. In this example, we can see that our result is non-significant because the blue diamond crosses the zero line. So when we make a subgroup analysis, we can see that the results are significant for the two groups separately. For the first group, the diamond is too thin because of the small confidence interval. That is why it seems to be a line instead of a diamond. And when we look at the heterogeneity values, we can see that both are lower than it was before. In the second group, we still have a significant heterogeneity because it's significant when it's higher than 50%. But this is caused of this study. And this can be some kind of outlier or something wrong with this, maybe. Heterogeneity can caused also by the different duration of follow-up. When we make a follow-up for a research, we can do it in two ways normally. One called per protocol. First, we make a randomization for the patients, and they started to be a member of the research. Some of them usually fall out from the follow-up somehow. It can cause of withdrawal of consent or lack of data, or a lot of other reasons can be. In case of per protocol analysis, we just use the data for the patients who were the member of the research till the end of it. The problem is that the fallout is not independent. For example, the more serious cases are more likely to fall out, which means that we can overestimate the effect of a medicine, for instance. The other problem is that in case of per protocol, our randomization is spoiled. The other type of evaluation is when we use all the randomized participants, even if they didn't get any treatment. That's called intention to treat. And thank you for your attention. I think I would like to give the word to Zsolt. Is there any question from the audience? If not, then I will give the word to Zsolt. Thank you.
So hi guys, I'm Zsolt here. Let's keep the break. Do you hear me? Please give me feedback.
We can hear you clear and loud in library.
Thank you very much, Balin. So continuing my presentation from yesterday, I'd like to introduce the concept of bias in randomized controlled trials today. About the table of contents, I'm going to talk a little bit about the pyramid of the evidence-based medicine. And then we continue with different types of biases. Starting with my first point, probably you're familiar with this slide. So if you take a look at this pyramid, we can see different levels. And each level of the pyramid represents a grade or level of evidence. Now, if you take a look at the middle of the pyramid, or maybe to the lower quadrant of the pyramid, you can find the case control studies, the uncontrolled studies, the cohort studies, as well as the cross-sectional studies over there. So these belong to the observational studies. And above this level, we can find the RCTs, the randomized controlled trials. Below these clinical studies, we have the case report, the case series, and the basic research, as well as the animal experiments. Now, if we go towards the top of the pyramid, we can see the summary publications, especially those which critically appraised multiple previous publications. So now, today, you have heard about randomized controlled trials, which are above observational studies if you take the level of evidence, which means that these studies are less vulnerable to bias compared to the observational ones, which means that the cause-effect relationship of the exposure of the drug you tested, of the intervention you tested, is more strict compared to the observational studies. Okay, so the causality increases if you go towards the top of the pyramid, while the risk of bias reduces if you go towards the top of the pyramid. So that's why we rather preferred evidence from randomized controlled trials if we'd like to make recommendations and guidelines. Now, turning to the first point, again, selection bias. You've seen this slide at least twice. Because it's a really important slide. Selection bias is one of the most important type of biases. And in this context we're going to talk about the right side of the slide. So selection bias as between group differences. So we don't care about representativeness because in the case of randomized controlled trials, the randomization itself doesn't provide any protection against the imperfect representativeness of the groups. So the question of representativeness occurs equally in randomized controlled trials and observational studies as well. Or maybe randomized controlled trials are less generalizable compared to observational studies. Why? Because the eligibility criteria are usually stricter compared to the observational studies, rather reflecting the everyday practice. Now, turning to our type of selection bias here, the between group differences, this is really important because randomization is the one which can neutralize it. Now, the first attempt for randomization was made in 1747 by James Lind in Edinburgh, when he wanted to treat scurvy and took 6 groups of people suffering from scurvy. Each group contained 2 patients. And randomly, he administered the interventions listed over there. Now, if you think about these, let's say, attempts of treatment, I think today it is no wonder that the orange and the lemon group showed any improvement. So all the others died till the end of the experiment. So this was the first randomized controlled trial. Why is randomization so protective against selection bias? So if you prepare a study and you don't allocate the patients by chance into the groups, then something else than chance will influence in which group the patient is allocated to. So if your opinion decides, then you are the one who decides. So it is really important. The chance is very important because the chance makes sure that the groups will be equally similar in all potential confounding variables in the baseline. Not only those we know that it has prognostic effect, but only those we don't know about them now. So randomization neutralizes the known and the yet unknown hidden prognostic factors as well. If you read a study, you have to make sure that it is truly randomized. First of all, you have to test or you have to check if the random sequence was correctly generated. Ideally, it is generated by computer. Earlier, they used random number tables. They are appropriate. Randomization by days. For example, all patients coming on Monday are allocated to one group, or those coming on Tuesday go to the other group. That's not random. So these are the so-called pseudo-random or quasi-random studies. Another pitfall, how was the sequence implemented? Because these sequences are usually generated in advance So let's say we generate the sequence for 100 patients in advance. Then if they come to the clinic, we randomize them one by one. We have the random numbers in the envelope, or the computer gives us the numbers. But I have a chance that I will somehow figure out in which group the patient will be allocated. For example, the envelope is transparent. So I can see through the numbers if I'm curious about, which can somehow influence my strategy to screen. So in an ideal randomized controlled trial, the sequence should be generated by computer truly randomly, and the sequence shouldn't be predictable. For example, the computer shares only the next allocation. Now, that was the example I showed you yesterday about the selection bias in observational studies, because that was a true and prospective cohort study where aspirin was tested against placebo or no aspirin. And the hypothesis was that aspirin reduces CV deaths within 10 years in the elderly. And yes, based on the results, the hypothesis should have been rejected because aspirin increased CV deaths among the patients tested. And I told you that this analysis was biased because if you take a look at the age of the participants, those allocated to aspirin group were older than those not receiving aspirin. So it's no wonder that they died more often. So then later on, they replicated this study in a randomized controlled setting, and it was a publication from New England Journal of Medicine as well. And while technically they found no difference. So aspirin didn't increase the risk of cardiovascular deaths in the elderly, but didn't have any protective effect against it. So aspirin had a neutral effect while the risk of bleeding was increased. So ideally, the hypothesis about the beneficial effect of aspirin, yes, it should have been rejected, but instead of making harm with aspirin, well, if you take the efficacy side only, here we have only a neutral association in the randomized setting. So that what can we see here? Well, the effects of bias in the observational study. Turning to other type of bias, let's talk about performance bias first. And let's have an ideal setting, a two-arm parallel experimental study, which is a randomized open label, so no one is blinded to anything. And I want to test a hypothetical drug to another one, and I wonder if it can reduce the risk of thrombosis or not. The patients are allocated in 1-to-1 ratio, and 20% of the patients with the old drug developed thrombosis, but 20% of the patients with the old drug were prescribed additional anticoagulants, while 85% of the patients with the new drug were prescribed additional anticoagulants in the other group. So technically, what we can see here is the unequal distribution of ancillary therapies. So the treating physician didn't trust in the new drug. Therefore, he administered ancillary anticoagulants more frequently compared to the other arm of the study. So no matter how I randomized in the beginning, yes, selection bias was eliminated in the beginning. Later on, due to the inequality of the additional therapies, the pure exposure of the tested drugs can't be established. So we don't see a cause-effect relationship here. Why was it? Because the study was open label, which means that the treating physician was not blinded. And the beliefs of the treating physician simply influenced the study. So that's what we call performance bias. It is really common, for example, in surgical practice, because blinding is not truly possible over there. A similar type of bias is the detection bias. The scenario is the same, but here, not the intervention, but the detection of the outcomes is affected by the beliefs of the treating physician. So if you don't trust the drug, you order more X-ray. You want to prevent pneumonia, but you order more X-ray with the new drug compared to that with the old drug. Oh, the chance of detecting pneumonia by accident simply increases. Again, the problem is lack of blinding. Now, another form of bias is the attrition bias, and it's very similar to the survivorship bias we were talking about yesterday. Sometimes the withdrawal or the dropout from the study arm is not equal. If we are talking about a theoretical experiment, again, a drug is tested against another one, and let's say the new drug has a side effect affecting only women, dysmenorrhea, whatever. So probably from that arm, more women will withdraw consent, or more women will drop out simply compared to the old drug. In this case, the distribution of genders will not be equal across study arms at the end of the study, while it was equal at the beginning of the study since the study was randomized. So that's what we call attrition bias, non-random dropout from the study arms. How can you prevent it from happening? Well, blinding worth nothing in this scenario. But as David mentioned before, we can apply intention to treat analysis instead of the per protocol analysis. Per protocol includes only those who received intervention, while we have the available outcomes as well. While intention to treat analysis includes all the participants randomized. Sometimes we have problems with it because if someone withdrew consent, we don't have the outcomes at the very end. So in this case, we have to impute. So what would happen if the patient had received the drug till the end of the study? Let's say carrying forward the last measurement, whatever. There are strategies for imputation. But always prefer intention to treat analysis over per protocol analysis in randomized studies. Turning to another type of bias, we can talk about reporting bias, very important. It means differences between reported and unreported findings. So for example, we are more likely to report the efficacy of the drugs than the potential harms. If you take a theoretical experiment only, we have a perfectly randomized double-blind study. So no detection bias, performance bias, selection bias, probably no attrition bias will affect your sample. And the drug reduced the mortality significantly. Again, they reduced the organ failure rate significantly. The short-term neurological deficit, the rate of it didn't change across the groups. Come on, based on these results, the one drug is superior over the other one. But if you add an additional point, and we realize that the long-term neurological deficit increased by 40% with this drug, it may change my strategy, how to interpret this recommendation at the level of guidelines, for example. So if you pick which outcome to report, that's reporting bias. By making protocols, study protocols in advance, so before you start recruiting, and of course you publish it, you can prevent reporting bias from distorting your conclusion. Take-home messages, again, the same as I told you yesterday, question the validity of the results always. Selection bias, information bias, and confounding, the major types. So performance bias and detection bias belongs to information bias rather. Pay close attention to the cause-effect relationships and always think about the pyramid of the evidence-based medicine. Thank you for your attention. And I think we can move to the last practice part. And you have an article available over there, a randomized control study, which is a recent piece of article because it deals with COVID-19 and the specific treatment for COVID-19. And your task is very simple. Please try to identify as many sources of bias as you can. And at the end of the task, please try to judge or try to decide how confident you are that the findings reflects the truth. So the conclusions of the study are not distorted by bias. Nori, how many minutes, what time do we have to close this session? Can you help me out?
20 minutes.
20 minutes. All right, so you have 25 minutes, please. All right. Actually, I don't know what groups we have. So can you help me out? Could you list me, please, the groups?
Okay, I name MedCheck group.
Okay. MedCheck group?
There's MedCheck, Peter's office, my office and library, and the online group as well. So we've got 5 groups.
Wonderful. So please, MedCheck group, selection bias. What do you think about it?
Hello there. As the authors themselves described, there was a possibility for selection bias due to the different stages between the different regions, like different stages of COVID or of the pandemic across different regions within India. But they tried, or they dealt with it by statistically adjusting for the trial sites, the primary outcome at least.
Which type of selection bias are you talking about, Alan? Are you talking about the general stability of the findings or the between group differences at the baseline?
General, I presume?
Yes, so we're not talking about the between group differences, because if you interpret selection bias as such, then we're not suspicious about it because the study is randomized actually. And we don't have any problem with the randomization process. So they use block randomization, computer generated sequences, whatever. What you mentioned, it is true, but it rather affects the representativeness of the findings. Or if you think back to the topics about the meta-analysis, that's the classical version of indirectness. So we're not sure that those patients included at the beginning of the study are similar to those included at the end of the study. So that's what you want to mean, if I understand you correctly. Please confirm me.
Yes.
All right, so that's a problem of general stability. All right, the next one, performance bias, detection bias. So let's handle these together. Let's have Peter's office now.
We think there is...
Could you speak up, please?
Can you hear me?
I can barely hear you.
Now?
Much better.
Okay. And one of the mics isn't working. So we think there is a possibility for both because it was unblinded. The study was unblinded, so for both for performance and detection bias, there is a possibility.
All right, can you tell me a story, a hypothetical story, how detection and performance bias can affect this study directly?
For example, the Indian doctors do not believe in the effectiveness of the plasma, which they are using, and that's why they are subscribing other therapies to the plasma group, which they do not subscribe to the control group. And as well as they don't believe in the effect of the plasma, and that's why they do more CT scans. This would be the detection bias.
You're absolutely right. Did the writers of the paper try to convince you that performance bias didn't affect the sample with any data shared? Let's take table 2. So if you look at table 2, at the bottom you have listed the most important ancillary therapies for each group, for the intervention and the control group as well. If you take a look at these ancillary therapies, you may find those drugs usually given against COVID-19 infection. And while they almost equally distribute between the groups. Of course, that's not definitive proof, but if you take only these common therapies, the groups were more or less equal. Otherwise, yes, so you're absolutely right that any ancillary therapies may differ across groups. Now, if you take detection bias, what was the primary outcome? Because it's really important to determine the primary outcome, because some types of outcomes are not vulnerable to detection bias. What was the primary outcome? Peter's office.
The progression to severe disease at any time within 28 days of enrollment and all-cause mortality at 28 days.
Composite of a clinical outcome and mortality. So assuming we had only mortality in this study, can detection bias affect mortality?
Maybe not, because that is dead.
So mortality is simple yes or no question, which is certain. So actually, those judging whether the patient is alive or die or already dead shouldn't be blinded. But as they established a composite outcome instead, and the composite contained a component about the gradient of something related.
Ratio of the inspired oxygen and the arterial oxygen tension.
Is that an objective outcome?
It's pretty objective.
It's pretty objective. So is it vulnerable to detection bias?
Maybe not so much.
How can it be affected by detection bias, theoretically?
Maybe they do more often a blood gas analysis in the
Yes, so
study
more
group.
measurements, simply more measurements. Yes. All right, thank you very much. Attrition bias. Do we have an online group as well?
Yes, we do.
All right, Szilárd, please, attrition bias, that's yours.
Someone from the group?
Come on, Szilárd, please.
I'm trying to force someone, but if no one is answering, that's a little bit hard. Can I ask again Lila to answer a little bit? To give a short answer?
Regarding
attrition
bias, what we discussed was that we looked at the figure 1, where they are showing us the trial profile, and what we saw that the same number of patients, almost a similar number of patients were in both of the groups, and the patients who were lost to follow up or discontinued intervention were also similar. So, yeah.
Yes, you're absolutely right. So in this regard, the flow chart, figure 1, is the most important figure you can pick. And as you confirmed, well, more or less the same number we drew from both arms. Did they apply intention to treat or per protocol analysis?
Sorry, can you repeat it, please? Because
Did they make intention to treat or per protocol analysis?
Both.
So they did both. And probably the strongest conclusion can be drawn from the from the results of the intention to treat analysis, but you can do both. All right, thank you very much. Reporting bias and sponsorship bias, these go together to Könyvtár, to library, please. Balint, are you there?
We are just discussing who should do it.
All right.
I can't choose. So many wants to do it.
You're in charge, please.
We've got someone allocated to this job.
Hello, everybody.
Hello.
Hello. Okay, so
Can you do your radio?
yes, of course. We can try it like this. So the reporting bias and the sponsorship bias, they can be checked in the study protocol, especially the reporting bias, to compare whether the outcomes of interest, for example, have been noted previously before the start of the trial itself in the first protocol. And we have checked that, and we think that this paper does not carry a significant risk of reporting bias. And regarding sponsorship bias, it can be checked in the acknowledgement section at the
Sorry,
funding.
before we move on, did you find the registration number of the trial in the paper?
Yes.
Where was it registered?
It was registered in the Clinical Trial Registry of India.
And did you check the date of the registration?
Yes, the date of the registration was around 10 days before the study itself.
And is it comparable to the time of starting the recruitment?
Yes, yes, it is. And it was made before the recruitment.
All right, very well done. So we don't have reporting bias, or yes, it is unlikely to distort the conclusion. That's probably more accurate phrasing. Now, moving to sponsorship bias, you started something to say. Please continue.
Yes, we can check the sponsorship bias in the funding section of the paper, which says that the study was funded by Indian Council of Medical Research, an autonomous government-funded medical research council. And the investigators from that council had no role in the activities regarding the research itself. And it also states that funding source has even no financial interest in the investigational product. So we think that the sponsorship bias is also unlikely to be found in this research.
Any pharmaceutical companies supporting this study?
None found.
All right, so that's a good point. So we're talking about a body of government,
yes,
a pharmaceutical company, and yes, probably they were not interested in proving that the convalescent plasma is more effective than placebo. Very well done. All right, would you share your opinion, how confident you are that these findings reflect the truth?
Well, we think that they do reflect the truth, but we are not experts in this topic, so maybe we should discuss our opinion with somebody who actually deals with such patients, at least.
Very diplomatic answer. What improvements would you suggest concerning those we are talking about today? Just those.
What regarding bias or what?
Yes.
Blinding would be necessary.
Would it be possible in this setting?
Yeah.
Why not? Yes.
Okay.
So you should make a dummy bag of plasma, simply. Probably it would have been possible. I honestly don't know why didn't make it blind. So probably they had a good reason for that. All right. So thank you very much for your contribution. Before we close this session, anyone, any question up their sleeves? Count back from 5, 4, 3, 2, 1, and no, then please. Thank you for your attention, and I hereby officially close the session.
Okay, thank you, Zsolt, for this wonderful lecture once again on biases. I would like to thank everyone for participating on this 2-day course. I'm happy to say that we are in advancing time, and because we skipped one break, we are able to finish these 2-day lectures on clinical trial. I hope you learned a lot and you are keen to work with us regarding clinical trials, and you have the motivation to conduct a clinical trial on yourself. So have a nice rest, and thank you, and bye.
Thank you, Lolly.
Bye, everyone.